Join us as we delve into the intricate world of risk adjustment in value-based care and payment models. Learn how this essential component is incorporated into VBC contracts, benefiting both payers and providers. Stay up to date with recent regulatory developments and policy shifts from V24 to V28 and how it impacts the implementation of risk adjustment in VBC contracts. Episode 1: Risk Adjustment and Providers. What are the opportunities and challenges?
Good morning. Today we have Dr. Decker join us to talk about risk adjustment and how the provider community feels about it and what they're anticipating to do in the wake of the new changes. Welcome, Dr. Decker.
Hi, great to be here with you today. Thank you.
What do you think? Are the providers aware of this great tsunami of changes coming their way?
I don't. I think that, that there's a lot of opportunity for learnings. It's interesting, having worked in risk adjustment really since the beginning, I know we would always look at programs and the approach was always, the alpha and the omega. So write everything down that you could about the patient. And over time, we evolved to focus on the most relevant conditions, but it was always to use an analogy, it was always this approach about throwing spaghetti at a wall and expecting or, believing that it would stick. And that's no longer the case. I mean, really with the changes, the things that folks need to be aware of is it's not enough to diagnose. You really have to make sure that you have care plans. How are you planning to address those conditions for which you are documenting, for that patient? And if that's not there, you do expose yourself as a physician. It's no longer enough. And like I said, having done this for a long time, remember discussions around, well, no one will question your clinical judgment. Well, now they will. And so you have to make sure that if you're diagnosing someone with a particular condition, you have to show what you're doing to treat that patient. And so that'll be really important to include in the documentation. And I think one of the things that's challenging is just the amount of work that requires to make sure that it's documented appropriately.
Yes, Dr. Decker, I think you are referring to the RADB final rule, which came on January 30th, 2023, and it will impact the way the providers practice.
That's correct. And I think one of the other things to note about that is there were several diagnoses that used to carry a risk adjustment value that were removed. Now, a lot of folks interpreted that to be that there would be an automatic decrease in the reimbursement. I don't think we can necessarily look at it that way. I think we need to look at it in its totality. So knowing that there are other factors such as those demographic values and some of the coefficients have been increased for particular conditions. Also, too, there's other social factors that are being taken into account, how many conditions a patient has. So lots of different factors figuring into that equation. But the thing is whether it's, you believe it's almost like Chicken Little, right? The sky is falling. Whether or not you believe that, and some groups have said, oh, it'll be a 20% decrease. I've heard others say, no, it'll be an increase. The thing that will be important is the accuracy of the diagnoses and making sure to document those things that are clinically relevant for the patient. And what I mean by that is, just even looking at diabetes, it used to be that there was a different value for a patient that had diabetes versus one with complications, so other manifestations. And that's been collapsed into one value. And I think that means a few things. One is that we've become very good, right, at diagnosing diabetes. We also know, too, that there are several complications or exacerbations that go with that condition. And so thinking that that's some of the reasoning behind collapsing it and providing it one value. But the other thing that's key there is really documenting the health journey of that patient. And so it's one thing to document the early disease stages, but knowing that you need to have that continuum of showing any progression of the condition. And I'll give an example. One of the conditions, I know I mentioned diabetes, but I think one of the conditions that's one that the community was really attuned to was peripheral vascular disease. And so it used to be that peripheral vascular disease without complications carried a value. And one of the comments that CMS made in that final notice was that after conferring with several physicians, really they want a model that reimburses or provides reimbursement for conditions that would be treated in the following year. And knowing that peripheral vascular disease, right, can have a different development. And so it may take time for it to reach more exacerbated stages that would require for treatment. And so it now has moved from peripheral vascular disease without complications to a more advanced version of the condition. So looking at things like resting pain, claudication, even ulceration and gangrene. And so again, looking at those more extreme versions of the condition as opposed to providing any reimbursement for those early stages. But here's the thing, in the whole thing of value-based care, the focus should never just be on risk adjustment and HCC value. It's important to document and test that condition early because we know, right, it's so prevalent in the community, but also not only documenting it early, but putting in place the interventions that would be important. And so talking about counseling the patient, right, around diet and exercise. Are there other types of interventions? Being aware, right, that it's part of their health condition so that it can be adequately monitored will be important. And being able to address just overall total cost of care, being able to address quality, right? Thinking about how certain ethnic groups might be unequally affected by this condition and what we're doing to address it. And so a lot more to think about than just writing a diagnosis in the medical note at this point. And so really thinking about what do these conditions mean, diagnosing them early, making sure that those that are clinically relevant, right, are captured and that you're identifying and documenting exactly what you're doing to treat the patient. What CMS and OIG and others have emphatically stated is that no longer can you put a condition in a note and not show that you're treating it. And so these once and done appearances of codes, right, are not appropriate. And I think about just the way some of the industry has operated over the years of let's call the patient in and write down every single condition that's true for them in that once and done visit, that once a year. It's not enough any longer. And so what we're really looking for and what the community and the industry are looking for is that those patients are being managed, right? And so we know that they should be seen more than once. If you're writing down that the patient has diabetes at the annual wellness visit, it's not enough, right? It needs to show at other places in the medical record of what you're doing to actively manage that patient.
Thank you, Dr. Decker. I think you're talking about the version 24 to version 28 changes, which came around in March of 2023 final rule, correct?
Correct. Mm-hmm.
Yeah. And I see a lot of similarities together between these two final notices or rules from CMS because there is more scrutiny on how the providers are providing care and that it is meaningful. And I think CMS has said that they are going to save about $11 billion because of these changes. But this is going out of practices for our MA plans and other VBC models. And how do you think providers can prepare for this change?
So what I would recommend, I think that there's a few things. One is making sure that you are documenting to the greatest level of specificity, like we've always recommended, but making sure that if you are treating those patients for particular conditions, being sure to document that and document it appropriately. It's not enough, right, just to yield the diagnosis, but actually show status and plan for that particular condition. To your point about RADV and the ability to make sure that they're protected in their value-based care contracts, having that documentation as a provider and a risk-bearing provider. And I've been a part of these groups that have been audited by health plans where they ask for particular records, really providing, I would recommend providing the entire record for the patient to substantiate those conditions. Just because a health plan says that on a particular day, a particular code was not substantiated, and now they can take money back, right? I mean, they always could, but the opportunity to take money back and in greater amounts, to your point about the monies that they're thinking that they'll recoup by looser documentation, if you will, the risk is much greater. And so making sure that you have appropriate documentation. The other thing that I would recommend is really investing in a very good platform. It's a lot of work, right? And it's a lot to make sure that you have appropriate documentation in the note for that particular visit. And so to the extent that you can invest in a system that will not only show you different conditions that have either been captured on that patient in the past, either on other claims, so that you can review them at the point of care with the patient, or maybe there are things that are, pieces of evidence that are put together that suggest a condition that maybe fell off of the medical record, will be really important, and to have that at the point of care so that you can document it adequately and accurately. The other thing I would say is making sure, a lot of times I know I've talked to a lot of physicians and they think that, oh, my EMR system will do that. They have these BPAs and that will be enough for me. It's not enough, right? It doesn't really bring together all the pieces of evidence that you need to look at, especially when you're in a risk-bearing contract. And then also too, it doesn't really allow you to provide the information back into the system and into the note that's necessary. The other thing too, I think to remember is that all EMR systems are not the same, and they may have been developed for different reasons. And so I can't tell you how often I've worked with different provider groups to understand that their EMR was not set up appropriately. They didn't have the right, say, specialty codes or particular codes or signatures or what have you. They just weren't set up in a way that optimized them being able to really capture the complete and accurate clinical portrait of that patient. Other things left out, they may only be billing 1 diagnosis code or 4 diagnosis codes. And we know that our senior patients especially oftentimes have far more than that. And so I think investing in a good platform that not only brings different disparate data, right, across the healthcare environment, if you will, or landscape, that bring together that portrait for the patient and being able to really evaluate that information and then document it appropriately, and having help because our physicians went to medical school, right, to treat patients, not to be these astute documenters, if you will. And so I think that there are a lot of systems out there that one can invest in that can help make this work a lot easier.
Great, that makes a lot of sense. Another downside to just using EMR, I think, is that it does not have all the data, which is coming from other sources, such as HRAs. Claims data is not typically there. So having a platform which is population-based, which gives you the rich longitudinal portrait of the patient. I think that's very critical. And also analyzing the notes where some of the unstructured data lives by NLP. I think these type of capabilities are now, they're no longer nice to have, they'll become must have, because the things are getting very tight, and the providers have to duly note and make sure that their documentation is up to the mark.
Absolutely agree. And I think to the extent that I want to make sure that we are using our clinicians in a way that's appropriate and to the top of their license. Part of the quintuple aim is to ensure that, not only that patients get the right care at the right time in the right way for the right price, but making sure that we keep our providers healthy as well. And so rather than, really weighing them down and doing all of this research and extrapolations themselves, bringing the information to the fore, letting them work at the top of license, work at that evaluation level, and really, review the information that's available for the patient, and then yield their clinical judgment will be important.
Great. I know that you also talk about how providers should widen their horizon and look at other ways to manage their populations, not just the providers, but population health managers and CMOs and VPs in general. They cannot just now lean on this one way of increasing their business, but they need to really look at the whole care continuum to see where are the levers that they need to press, not only to improve their care, but also to improve their revenue and their bottom line. So what are some of the other things that you would recommend that providers look at it holistically to improve that?
Well, I think that there are a lot of components that go into how a patient takes up healthcare. And so if you're not seeing patients on a regular basis, but you know that they have particular conditions, don't be surprised, right, when they show up at the ER. And so if you're in a risk-bearing contract, oftentimes you're responsible, right, if it includes that portion, which most of them do now, of managing the patient appropriately. And if there are things that you can be doing in your office versus referring to a specialist if it's unnecessary, or where the patient, like I said, is going to the ER for services. If there are things that you can identify, and again, there are platforms out there, right? And I know Persivia to be one, where they're bringing together different aspects of the data. So not just the pure clinical, right? All the diagnoses, but other things about the patients too, and who are at risk for ending up, say, in the ER, or aren't taking their medications regularly, when we know that if they're prescribed a statin, right, could do a lot to change their health outcome. And so it isn't just about capturing conditions today or documenting them appropriately, but also making sure that, you're fulfilling all the components that are required around, say, quality, making sure patients are getting their mammograms on schedule, making sure that they're getting their appropriate vaccinations every year, or, whatever schedule is appropriate, depending on, what those are. And then again, making sure for site of care, right, that they're using the appropriate channels and seeing you in the office, versus showing up at some of these other places that I've mentioned that are far more costly and really aren't the appropriate place to get the care that's needed, right? They're only going to be referred back to you oftentimes because they're not going to get those services in the ER. And so knowing who those patients are and being proactive in trying to manage them best, like I said, at the right place in the right way for the right cost, and so on and so forth.
That makes a lot of sense, Dr. Decker. It'd be very interesting for us to watch and see that this tightening of HCC regulations, what type of impact it does really have on practices and population management. As you have said that we need to be more mindful of providing appropriate care at the appropriate time, doing the screenings, doing the AWVs so that our patients stay away from the ER, and decrease those readmissions become important. Let's see other people see that shift and see this as a driver for that shift or not. So I'm very eager to see how the story unfolds. But thank you so much for joining us today. If you have any concluding comments, please say those.
You know, just to add on to what you were saying, and another insight is, you know, it's not enough to mention things. The timeliness of the work that we're doing is so critical. And so in the past, we had the benefit of submitting data after with these new programs and the way in which physicians are responsible in these value-based care contracts for the care of patients. It's super important to make sure that you are capturing this information and submitting it on a regular, timely basis, because it really will influence reimbursement rates and having money available to fund those programs, right? To make sure that patients are getting the appropriate care. There's different schedules depending on whether or not it's Medicare Advantage, you've taken commercial risk, right? You're an ACO, Medicaid. It's really important to be aware of that. But again, I think the best way, rather than managing all those submission schedules in the calendar, is submitting data accurately, adequately, and completely, so comprehensively, on a regular basis. And I really recommend making sure that you have the right platform that's complete, and that you're submitting things at least on a monthly basis, just to make sure that you have that revenue integrity, right? You're not getting reimbursement that you're really unsure of, that you're chasing after, that you need to have to be available to fund the programs that you're trying to do for your patients. And so making sure, again, that you're paying attention to not only the comprehensiveness of the medical record and the population health and the programs and things like that, but also the timeliness of it all as well.
That makes a lot of sense, Dr. Decker. I couldn't agree more. The timeliness is very, very critical, and seeing it as a totality, as whole, with your attributed population, for instance, can impact your risk contracts. Having the right attribution model, having the right data to submit, that's so critical at the right time. So thank you so much for joining us. This was a great learning experience for us, and we'll see you soon. Take care. Bye-bye.
Thank you.